Now, a very controversial subject.
Okay.
Secondary erythrocytosis due to testosterone replacement. Again, secondary erythrocytosis is when you do testosterone replacement therapy, testosterone therapy, it increases your blood count, your hemoglobin, your hematocrit, and we're not sure what to do with this. There are no good studies to help guide us. So what do you do with this? And I know you were doing a study on this.
Yeah, we actually published the results, so I'm happy to tell you this. So testosterone therapy can cause increase in hematocrit. The underlying mechanism, not very clear, but people think it can happen because of three things. One, it can probably cause more sleep apnea, leading to or worsening of the sleep apnea if patients have pre-existing sleep apnea. So in patients who already have a high hematocrit and a low testosterone level, I think the first thing to do is to screen for sleep apnea. And actually even send them for a sleep study, because if you start treating them, now everything gets muddled. Number two, we think that it possibly changes the erythropoietin level production from the kidney. So increase in testosterone increases erythropoietin, makes more hemoglobin and hematocrit. And number three, we think it alters the hepcidin set point in the liver, which could lead to reabsorption of heme and an increase in hematocrit. So those are the three hypotheses. We truly don't think don't know the exact mechanism. Having said that, I think just about every form of testosterone therapy can lead to increases in hematocrit, regardless of whether it's the intramuscular route, the oral route, or the topical gel route. And we've published data showing that all of them seem to do it. So far, the whole association between testosterone and cardiovascular risk, we were just like, hey, it's association. One possible mechanism that could tie between the two is the blood getting thicker. Right? If now the blood viscosity is higher, there's more red blood cells, they could clog up arteries or veins and lead to adverse cardiovascular events. And we actually, in our first population-based study in the United States, basically showed that in people in that first year, if you get testosterone therapy and your hematocrit goes up beyond 52%, so 52%, then you are at an increased risk of heart attack, stroke, and blood clots in the legs and in the lungs. So that was the first marker that basically showed that maybe we should be very aggressive with hematocrits. We, in practice, are used to this. This is what we do for a living. We check hematocrits. We are aggressive. So if the hematocrit is above 50%, I usually start recommending them to go to phlebotomy, right? Either donate blood or phlebotomy. I do not let them get to above 50%. And this is why we aggressively monitor them during that first year of testosterone therapy. Most people in general practice do not do that. They get a prescription of testosterone, they come back in a year, or they come back in 6 months, call back for a refill. And so none of this follow-up exactly happens. So I think it's very important for us. Men should realize that this is a steroid and it needs to be followed up closely.
Monitored,
And this is not something like a blood pressure pill or a diabetes pill where you just take home and you come back in a year for follow-up. And so I think that's why it's important. So yes, so polycythemia can happen, erythrocytosis can happen, and the above number 52 seems to have some bad effects. It's an association study, but we still think that delta, because a guy that goes from 46 to 52 is very different from a guy that goes from 38 to 48. And I truly think the guy that goes from 38 to 48 is a lot worse than the guy that goes from 48 to 52. So I don't think there's anything magical about that 52. I think we just saw a lot of people that went to that range and then started getting effects. But I think the change in hematocrit is also probably very important, because if that blood gets thick like that within 3 months, I'm fairly certain it's going to have some pathologic effects if we don't do anything about it.
How much blood do you recommend to donate? Like
usually, so if it's
whole blood, right?
Yeah, whole blood. Yes. So if it's or PRVCs, I mean, you just want to bring the hemoglobin down. So usually, if it's above 50, if it's 50 to 55, then I usually ask them to give at least 1 or 2 units every 3 to 4 weeks. And if it's above 55, then I get a little bit more aggressive and I ask them to do 1 or 2 units every other week. By that time, I've also switched their testosterone therapies around. I've either decreased their dose, most likely increased their frequency instead, because we see a lot of hematocrit changes with people who have like 200 milligram doses every 2 weeks. That's actually way more common. Like most endocrinologists do that at 200 milligrams every 2 weeks. And then so I usually switch them to 100 milligrams every week if they're doing cypionate or enanthate, and sometimes even 50 twice a week if we have to do that. It's
Very
the, it's,
good.
Yeah, we like the
We're like 2 to
decrease
3
and
times a
increasing
week.
the.
So you don't have the high peaks.
Yeah.
Because it seems like the high peaks is what's really correlated
Right.
to the higher.
It's a lower
and the
impact on
large,
the bicep.
and the large area under the curve.
So this is really important thing because like when you look at most testosterone discussion forums, there was no study.
Right.
So now we know above 52.
Right.
And did your study show it was just in the first year?
First year.
What if first year you never had it, but then it happens later?
There's no association.
So
really
again,
the
for
first year.
us, we know, and we
beginning.
monitor our patients the first year 3 times.
Perfect.
Then it's usually twice a year. That
There
we
you go.
follow.
That's exactly right. Yeah.
And then we do recommend phlebotomy when needed.
Right.
The one issue I've seen with some of my patients who donate blood too often, their ferritin level goes down. So now they become iron deficient and they're tired.
Yeah.
So we have ways to deal with
Right.
this.
Yeah, it's an art.
Yeah, it's an art to know how.
No,
to
but
do
if you're
this.
already giving blood too often and that is happening, we have to think about
Yeah,
testosterone
but
therapy.
another
right?
way of
Either to
this.
change the route or change the dosage. Something's happening in the back end. So
Good.
Do you have a way in layman's terms to explain to the audience the difference between polycythemia and secondary erythrocytosis? Because a lot of people have that confusion. Very short way of
Sure,
explaining
both of them are actually erythrocytosis is any increase in blood count. So if it goes from 38 to 48, that's erythrocytosis. Your hematocrit. Polycythemia is a defined number. So if the hematocrit's above 52%, then it's true that's polycythemia.
Polycythemia.
So if it doesn't reach 52%, we don't call it polycythemia.
Okay.
So erythrocytosis is any increase in number in hematocrit or hemoglobin. Polycythemia is defined as greater than 52, or some guidelines say 54%.
And what's confusing when you say polycythemia, a lot of physicians still, when you say polycythemia, they think P. vera. Polycythemia vera,
Vera, yeah.
which is an hematologic malignancy
Right.
that is associated with higher risk of heart attacks and strokes.
Right.
So the doctors will call me, my patient has P. vera now. I'm like, no, you didn't do a bone marrow. He has polycythemia, but it's not P. vera.
Right.
So great studies. So we are aggressive. So now we have more on how to guide us. Really quick, a lot of doctors I see do this. I don't do it. When they see the patients going higher, they put on a baby aspirin. I don't think there's any studies to show, especially now, we're seeing that primary prevention with baby aspirin is not good.
Yeah, exactly.
So
I don't
that's
do
not
that.
something.
Absolutely not.
Very good. So now I know for
last one.
time, one thing.
Yes.
Fertility.
Yeah.
So
Fertility.
first,
This is huge.
what happens in restoration of fertility? I know that's your area.
Right.
And I think just to kind of contextualize it, because as we've told you, 47% of our patients are under 40.
Right.
And so you get a guy that is the victim of this new era of low T,
Right.
that we're seeing so commonly.
Right.
And then he's considering getting on testosterone, but he either wants to have more children or
Right.
hasn't had his first child, right?
Right.
And so the concern is, oh my gosh, well, if I use testosterone, then I'm going to be infertile forever.
Right.
And I think one of the most sort of like landmark studies that were out there was your study where you showed that, and correct me if I'm wrong, and I'll let you talk about the study where you took hundreds of participants that had been on testosterone
Since their
testosterone
teens.
therapy for 10 years plus
Yeah.
without the use of any of these common fertility medications like
Right.
HCG or clomiphene, and you were able to restore them back to fertility.
Right. So,
us about that.
so I
That's
think
amazing.
so. You say that it's very easy for you to say that testosterone therapy causes fertility because you're in this business. But in clinic, we probably see 1 to 2 patients every day that come to us with no sperm at all, with a very angry and an unhappy wife and an unhappy patient telling us that nobody told them that testosterone therapy causes infertility,
Right.
or testosterone therapy is a contraceptive, right? That is proven beyond doubt.
Right.
I think it's very important for people to first understand that they are taking a contraceptive.
Right.
And the one assumption that we often make, and especially now COVID's changed things a lot, is we think just because men are older that they're done having kids. And now, especially in Miami and South Florida, we're seeing a lot of older men who now want to have kids.
Yeah.
50-year-old, 60-year-old, 65, 73, I did a sperm retrieval on another day. The guy wants to have a kid. So I think
Good for him.
we shouldn't be discounting that, just because you're older, he's probably done with his family. So I think that sort of education needs to go in anytime we're thinking about testosterone therapy. Good news, I think, yes, most patients on testosterone therapy can be recovered with Clomid and or HCG based on what their levels are and how long they've used it for. 95% of the time, if they made sperm before their testosterone therapy, they'll likely make sperm after testosterone therapy. There's one caveat. We have no idea if they ever made sperm before they started in their teens. Nobody ever checked a sperm count when they started it at 22, 23. I often now just check a sperm count. If it's a 28-year-old and comes to tell me, Doc, I'm not thinking about kids, I just want testosterone therapy, I'm like, check a sperm count.
Yep.
Because I don't want you to have 0 sperm count and then 10 years later come back and say, Doc, I want my sperm back. You're not getting your sperm back because you never made any. So I think now that we talked about declining T levels, there's declining sperm levels.
Right.
And so I think that's why it's important for us to make sure that we not just educate the patient that's starting testosterone therapy, but that wants to come off of testosterone therapy, that there is a good chance that they'll get their sperm back, but also understand if they never made it before, they're not going to make it.
Right, that's the caveat.
Right.
What's the health status of these patients that you see? You said 1 or 2 that come to the office are not producing sperm.
I mean, they're fine, but they're not so small. Right? Because they've taken testosterone therapy for a very long time. They've had testicular atrophy. They're doing great and they feel great. They're very unhappy. They need to come off of testosterone. But they have testicular atrophy and then therefore that there is no sperm.
So a few comments on this. Definitely when we do our consultation, I spend a lot of time with my patients asking them, do you want more kids? Where are you with kids?
Right.
And then I counsel them. When I have my younger patients who don't have kids yet and may want kids, I will usually start with Clomid or HCG monotherapy, and we get some results. Again, Clomid is not great. Sometimes we've had patients with Clomid that increase testosterone levels, but you know what? Their symptomatology did not improve. So at least, but we can try. Second, we've had a few patients that we've had on testosterone plus HCG who got their girls pregnant. So testosterone is a contraceptive, but it's not 100% foolproof, especially if you add
terrible
HCG.
contraceptive.
Terrible. And then the third thing, which your study now, because the scare that a lot of people would have, and it's in every book, that it may cause irreversible infertility issues. So most likely those irreversible is because they didn't make sperm from the beginning, but we cannot prove it. So 95% of patients on long-term testosterone therapy were able to restore their fertility. This is amazing.
It's incredible.
This is amazing.
I'm proud of you, man. Thank you so much for your work. Like, really.
Absolutely.
We use that a lot.
I say your name all the time when I do my talk.
Yeah,
so.
you're in our speech a lot.
So it's amazing, and I think
well, I think a lot of myths were busted today. So thank you for your time.
Absolutely.
Dr. Ramasamy.
No, thank you. To an educated, and I truly want to say you guys are just up to date with the literature, up to date with the studies, know the risks, know the benefits, spend time counseling.
For sure.
I think this is not what happens in the real world.
Not right.
Especially now post-COVID, we have so many of these online clinics that are now prescribing testosterone. Some of these clinics do a great job in counseling, have actual doctors that are trained in testosterone therapy, have nursing visits to discuss risks and benefits before giving testosterone therapy. Most clinics don't do all of those things, and patients get these false printouts.
They don't even test for PSA. You know how many labs I've gotten without PSA levels?
I see 4 lines with four numbers without the name or the date of birth, and I have no idea where these numbers came from. And the patients come to us and tell us, this is my testosterone level. These are my labs.
No, we pride ourselves in really doing a lot of counseling. Or lab tests that we do, we check one.
Super extensive.
We always check LH. We check estradiol.
Always PSA. Always PSA.
And it would be actually more extensive. It's just that it becomes unaffordable for a lot of people, patients, right? We're actually talking about extending it to have 2 choices for depending on the person, right?
So, Doc, I know you don't have that much time left, but I want to talk about erectile dysfunction. My God. It's an epidemic that we're seeing. I know, those companies now that does the online platform and send you Viagra. I won't say the name here. But what the average age of patient receiving Viagra from those online platforms, I think we discussed this. So what was the average age?
Wait, they'll send you Viagra and finasteride.
Yes.
Both in the same package.
Yes, probably around 30 to 35, right? I mean, it's anonymous. Patients can get it from the comfort of their home. I think it's done both good and bad.
It's done good.
The one good it has done is it has broken the myth of, oh my gosh, I have ED. And so therefore patients are able to access it easily. They don't have to oh my gosh, go sit in a doctor's office, think about this medicine all the time and then able to get it. But the bad is like they're not getting an evaluation. They could have an underlying problem, and now they're getting it at a very young age, and we just don't know the long-term impact of what this.
And they're
is going
using
to
it without
happen.
strategy. I mean, they're just taking it like Skittles. So
Right.
So let me ask you, what's the incidence of ED? I was trying to look it up. It's very
So
confusing.
it's 50% above the age of 50.
Above the age of 50%.
So 1 in 2 men above the age of 50 will have some sort of erectile dysfunction during their lifetime.
What about in the younger population? That's what I was looking, because we're seeing more 20-year-old and 30-year-old using those online platforms.
Right.
And if they use Viagra, it's because I don't even call it ED anymore. I like to call it EP, erectile problems. So it may not be that you have dysfunction, but if you missed one time, or if it's not as strong as it used to be, and then now it becomes in your head, and then it becomes worse. So the way we deal with this, there's no questions that a lot of the patients coming to us with testosterone deficiency symptoms, their symptoms include, don't have to, but very often you have low libido or decreased erection, like morning erection, strength of erection, reliability of erection. So what we've seen that a lot of our patients improve just by restoring their testosterone level. Usually if that doesn't work, then we add daily low-dose
PD5 inhibitors,
With this, we get maybe 60, 2/3 of our patients.
Perfect.
But we do have patients that you optimize their testosterone, you put them on daily Cialis, they exercise, they eat well, and they still have
shockwave even.
We've done shockwave that has helped a few patients. He's one of the busiest guys down here doing penile implants. Because for some patients, you do all of this, but unfortunately, you go all the way down. So the other thing I wanted to talk to you about, and I think you're doing a study on this, stem cell penile injections. What do you think about that?
So very new. So we actively are doing the study on, not on stem cells, but on PRP. So basically platelet-rich plasma, we draw patients' blood and then spin down the growth factors and inject it. We're doing a placebo-controlled trial. Actually, the results should be available within the next few months. Happy to report it to you guys.
I can't wait.
And we're trying to see if that improves it. We're actually performing an NIH-funded study. Taxpayer dollars. For the first time, the government thought we need to study erectile dysfunction in humans.
Wow, look at that.
First
That's how serious it
got. First ever clinical study.
I bet you one of the guys funding it probably has it.
We should study it. That's
And
great.
so for the first time, they're funding a study on erectile dysfunction where we're doing combined shockwave therapy and platelet-rich plasma and trying to see if these both have synergistic effects on erectile function. And we're doing a 6-month follow-up. So all of these studies hopefully will have results.
You're doing a shockwave and then administering?
And PRP right away.
Right away.
Trying to see if
We're definitely going to be
trying to see if we can keep the platelet-rich plasma within the in an inflamed state and try to see if that has more of an impact than monotherapy. So all of these studies are happening. We just don't have any data. It's being given out in many clinics everywhere. There's every radio ad on shockwave therapy, PRP, P-shot training. I just don't have any data. So far, we know that it's safe. We haven't seen adverse effects, but efficacy on whether it works, I have no idea. I'm sure it's not going to work in everybody. I'm optimistic that it's going to work in a small percentage of the population. We just need to figure out who that is.
What about bone marrow-derived stem cells for penile injections? I've seen a few studies with positive resuls. What do you think?
Bone marrow-derived or fat-derived?
No,
So
bone,
adipose-derived stem cells. Those studies are almost like they're either done as part of another study, but really there's very little literature. Stem cells, I'm very scared just because of its potential to become another cell and potentially become cancer. And so the risk of stem cell injections are way more than P-shot or PRP and or shockwave therapy. So anybody thinking about getting stem cells, I think we're very, very scared.
Yeah, especially since you're extracting CD34, which is
stem cell, correct. That can potentially become cancers. So yes, that is risky. So
one thing I want to say for our viewers, people listening to us, first, we need to normalize talking about erections. Men out there, young men, older men, it happens to 50% of men over 50. It happens to a large number of younger men. And if that happens to you, we know the psychological impact that this has. So if you suffer from this, my advice for my guys in the clinic, I'm like, we're gonna help you with your erection no matter what. Whether it's testosterone, whether it's daily Cialis, whether it's shockwave, we're gonna try. The goal is to prevent them from going to you and getting a penile implant. But I even tell my guys, if that's what you need, do it. Because you know what? There is enough science now to say, first, ED, because I think, with our talk with Dr. Anthony J, the toxic world we live in is causing more and more ED. The same way it's causing more infertility. So if a man suffers from EP, erectile problems, find help. Don't let it define you. Don't let it get you down, because that's what we see a lot. Men who have erectile problems internalize the shame and have all kinds of psychological issues.
Yeah, it becomes a sort of like a
vicious cycle.
Vicious cycle, of self-fulfilling prophecy. You know, it destroys the dynamic in relationships. I mean, it's really, and it's a tough conversation to have. Luckily, we've created a safe space and we've mastered the conversation because we've been through it, right? So,
and if needed, if you need a penile implant, that's what you need. What did you tell me? 95% satisfaction rate?
Right.
If you get to that stage, if that's what needs to get you there, do it. Don't let erections hold you back. And we need to talk about it. We need to normalize it.
Well, Doc, I just want to thank you. I think I speak for all of us. We're proud of you. Thank you for your work. Thank you for the investment in the time that you've made, and you're an amazing researcher. We look forward to all the studies that you're going to be doing. I'm sure we're going to be talking a lot more and calling you and annoying you a lot more. But thank you for your time. Thank you for being with us. We really appreciate it. And for all of those of you watching, if this is one of you, just give us a call. This is an area you're not alone. You're not the only one with this problem. I think we've done a lot in demystifying a lot of testosterone, complicated sort of literature and myths. And so if you have any more questions, please give us a call and we'll point you in the right direction. And if you need to see Dr. Ramasamy, that's exactly where we're going to send you, because you'll be in great hands. So for now, thank you for watching. Stay healthy and God bless.
Thank you.